dysbiosis within the gastrointestinal tract. Other conditions, for example, like fibromyalgia, are also very tightly connected with gut microbial imbalances and dysbiosis, and that affects the reception of pain and depression and anxiety in those patients. Also, we see, for example, that patients who have depression often have gastrointestinal dysbiosis, higher levels of bacterial translocation and bacterial endotoxin, and also a heightened immune response against bacterial structures such as endotoxin, for example. So we definitely see connections, kind of a spectrum of gut microbiome and brain and mood disorders. As I've said throughout this program, a lot of times we can't kind of pin the tail, so to speak, on a singular microbial donkey and say, this microbe is causing this problem. So for example, even though more and more studies have delineated specific microbial imbalances in autism, I don't think we're ever going to find a microbe that is fully responsible for autism. What we're looking at is a clinical phenotype that is affected by many different influences, a very strong one of which is gut microbial dysbiosis. But as I've emphasized throughout the program, what I want you to focus on is the clinical phenotype, and then thinking about what actions you can take to address or correct that phenotype rather than trying to hunt down individual microbes. Occasionally we do see direct correlations between these dysbiotic microbes and the long-term diseases and disorders that they can cause. Streptococcus pyogenes clearly contributes to psoriasis. It's not the only microbe involved, but Streptococcus pyogenes is certainly the leader of the gang, so to speak. It is certainly the most responsible microbe for psoriasis, generally speaking. However, in most other diseases, as I said previously on this same page, we're not going to find a specific microbe causing the disease. So we have to think more broadly, and when we think more broadly, we have to think about what can we do to modify microbial balance, not trying to target specific microbes, not trying to use specific antibiotics, unless that patient's unique case gives us reason to target a particular microbe. When we look generally at the data, we're not getting the impression that we need to target a specific microbe in these specific clinical phenotypes. So again, I encourage you to look at the clinical phenotype, take the information that you've gotten from this class. Hello everyone, Dr. Alex Vasquez here with our program on human microbiome and dysbiosis in clinical disease. This is the video series that accompanies the printed monograph. In that monograph, you also have most of the printed presentation slides, and you also have password protected access to more than 12 hours of additional video to help you understand and clinically apply this information. What I'm going to do right now is focus on what I consider to be the core highlights of the information. I'll walk you through some case reports so that we can apply that information clinically, because of course the emphasis of the program is the translation of basic sciences into clinical practice. You'll find this to be particularly relevant for patients with diabetes, obesity, insulin resistance, and cardiometabolic disease, fibromyalgia, chronic fatigue syndrome, which has recently been renamed systemic exertion intolerance disease. Also, I will discuss some neuropsychiatric conditions such as autism and chronic pain and depression. And of course, major emphasis will be placed on the autoimmune and rheumatic diseases such as psoriasis, rheumatoid arthritis, lupus, Sjogren's syndrome, and multiple sclerosis. This slide provides a listing of the core content, and you might also use this as a mental checklist. We start with a pretest, and that allows us to assess baseline knowledge. It also allows us to assess the overall effectiveness of this learning program. Then we have the printed monograph, and then of course now we are entering into the video series and the video presentations. After we've gone through the pretest, the printed monograph, and the video presentations, then we access the final exam, and that gives you a chance to complete the program and print off your certificate of achievement. So again, taking our focus back to the video presentations, we're starting right now with number 1, which is pathophysiologic mechanisms. I'll also talk about microbes, molecules, and morphology. So what the science shows us is that hydrogen sulfide is a mitochondrial poison very similar to cyanide, except that hydrogen sulfide is produced from microbes within the gastrointestinal tract. So we want to consider addressing this component anytime we're dealing with a patient who has what I call dysbiotic mitochondriopathy. So this is a mitochondrial disorder caused by dysbiosis because now we have evidence very clearly that these gastrointestinal bacteria can produce mitochondrial toxins. D-lactic acid is a mitochondrial toxin produced by gastrointestinal bacteria. Hydrogen sulfide is also a mitochondrial toxin produced by gastrointestinal bacteria. And I showed you earlier that endotoxin from gram-negative bacteria also produces mitochondrial dysfunction. So I think many of you will find interest in the fact that you can bind or neutralize hydrogen sulfide by using a specific vitamin, and I'll show you that in just a moment. Let's substantiate this concept just a little bit more before we move on to clinical applications. Microbial pathways in colonic sulfur metabolism and links with health and disease. You can see this was published in Frontiers in Physiology in November of 2012. Now we have arrived at the end of this presentation, so let's all take a deep breath, congratulate ourselves. We just talked about the microbial mechanisms, molecules, and morphology. We're now going to move on to the next video in the series, and we're going to focus on pathophysiologic responses triggered by these microbial exposures, and that will help us transition from microbes through pathophysiology and ultimately to clinical prototypes and more ways that we can manage the microbiome and dysbiotic responses in clinical practice. So I look forward to presenting that information on pathophysiologic responses that serve as the interface between the microbe and the clinical outcomes that we see in our practices.